Thank you. Okay, so let's start again. So everybody got a pen and paper, and I'm going to ask you a few questions first before I go on to the lecture. So the first question is, what are the various parts of the mediastinum? And draw the mediastinum. Okay. So draw the mediastinum. Everybody's done that? Okay. Now, we all know about mediastinal lymph nodes. Yeah? Okay. So write down Naruke's classification of mediastinal lymphadenopathy. What is the Naruke's classification of mediastinal lymphadenopathy? Yeah? You got that? Okay. Next question, surgical question, okay? Not surgical question, but clinical question. Tell me about all the various methods that you can use to stage the mediastinum. So this is just a starter, okay? This is not the talk. So this is just a starter to get you thinking. Okay, because I'm going to ask you to answer the first question. What are the various parts of the mediastinum? Just simple. It's a very straightforward question.
We can divide it into anterior mediastinum. We can divide it into anterior mediastinum, middle mediastinum, and lymph mediastinum. Structures in the anterior mediastinum would be the.
How do you divide it into anterior mediastinum, middle mediastinum, and posterior? What are the boundaries?
Anterior, for the anterior mediastinum, anterior boundary is the posterior surface of sternum, and the posterior boundary is the great vessels and the pericardium. The
we are teaching and learning. So, anterior mediastinum, the anterior boundary is the posterior surface of sternum, and the posterior boundary is the mediastinum. How do you?
The structure.
No. How do you classify middle mediastinum?
The structure between the two anterior pericardium and posterior pericardium. Both the things is the middle mediastinum.
Acceptable. Posterior mediastinum. How do you classify posterior mediastinum?
The structures behind the pericardium and till the spinal column is the posterior mediastinum.
Okay, that's kind. What is superior mediastinum?
It is divided by the line drawn from the angle of Lewis, going behind it up to the origin of great vessels. So structures above this are the superior mediastinum. Structures below are the inferior mediastinum.
So this is very good, very basic. Everybody happy with this? Anybody's got any questions? Step in, okay? Before we start discussing staging, I just want to understand the anatomy. Anybody's got any questions? You can step in, okay? All right. Next question that I asked you was, I will ask, let me see who else is there acutely examining. Who's acutely examining? Okay. Ramaswamy on with me. Ramaswamy, are you there?
Hello. Yes, sir.
Don't be scared. Okay, Ramaswamy.
Yes, sir.
Tell me about Naruke's classification of spinal lymph nodes. Oslo.
Okay.
Don't know, say I don't know.
Sir, I don't know, sir.
Okay, that's fine. Anybody else wants to take up? It's all right not to know, okay? Don't worry about it. That's why we are here. Anybody else wants to take up? Is Nikhil online here? My Nikhil is online? Not online. Okay, Nikhil Bansal, do you want to take up? Okay, I can see. Pallavi is there, is it?
Yes, sir.
Okay, Pallavi, you take on. Go slowly, because before we start talking, I want everybody to understand.
So the basic difference between
Classification of lymph nodes.
Sir, Naruki's classification of mediastinal lymph nodes was given by the Japanese association. It is slightly similar to the ISLC classification, which was adopted from the Mount Dressler's staging system.
Good.
But the 7 and the 10 lymph node stations of the 7th station of the Mountain Dressler system is considered as station 10 of the Naruki's classification.
Okay, stop. Just 1 minute. Excellent. So what I want you to understand is that there are 3 types of classification. Okay, the old one was Mountain Dresslers, the next one was Naruke, and the one that is used now is the international classification of IASLC classification, International Association for Staging of Lung Cancer. So whenever you talk about mediastinal lymph nodes, you have to talk about IASLC classification. Everybody with me? So always say IASLC, and then somebody may throw in what is Naruke's classification. If you know it, that's good. If you don't know it, that doesn't matter. As long as you know IASLC classification. Okay, come back, Pallavi. And
yes, sir.
Talk about the various stages of the various levels of the IASLC classification of mediastinal lymph nodes.
Sir, station 1 is the highest mediastinal. Station 2R is right paratracheal. Station 2L.
Pallavi, go slow. Station 1 is the highest mediastinal, which actually corresponds with the station 6 of the neck level of classification. Okay?
Yes, sir.
When you have head and neck cancers, they have their lymph nodes classified as 1, 2, 3, 4, 5, 6. So 6 of neck is the same as 1 of mediastinum, but it lies outside the mediastinum. It is right at the apex where the pleura tends, and it's just there. Okay, so it's station 1. Good, Pallavi. Station 2?
2R is right upper paratracheal. Okay. 2L is left upper paratracheal. Good,
very good. 3?
3 is 3A and 3P. Okay, 3A is prevascular. Yes. And 3P is,
retrotracheal.
Retrotracheal.
Okay. So stop there. Stop for a minute. Stop. So 2 is high mediastinal paratracheal. Okay. 1 is highest mediastinal. 2 is high mediastinal, high paratracheal. 3 is divided into A and P. A is in front of the vessels and P is behind the trachea. Okay. Okay. Go to number 4.
So 4R is right lower paratracheal. 4L is left lower paratracheal.
Okay, Pallavi, stop. Question to you. What divides 2 from 4?
So on the right side, it is the azygous vein. And on the left side, sir, I don't remember exactly. I'm sorry.
Okay. Actually, if you really look at it technically in great detail, it is the superior intercostal vessel vein which divides 2 from 4 rather than the azygous. We all say azygous divides 2 and 4, but actually it is, if you really look into the depths of this analysis, then it's the superior intercostal vein which divides the brachiocephalic vein, the level of the brachiocephalic vein. That's what divides 2 from 4. Okay. All right, on both sides. Okay.
Yes.
On the left, on the right side, you don't have the brachiocephalic, but you know what the level is, where it crosses across. Okay.
5 is AP window, 6 is para-aortic.
Okay. Where is AP window?
7 is
One minute. Wait. 5 is AP window. Is it subaortic or pre-aortic?
Sir, it is subaortic.
Okay. And 6 is?
6 is para-aortic.
So if you have an arch of aorta and you have your pulmonary artery where the PDA, the ligamentum arteriosum lies, if you take a lymph node from that area, what have you got?
Subaortic.
Which is which number? Give me a number.
AP window, 5.
5. Very good. And if you've taken one from in front of the aorta?
That is 6.
Good. This is a differentiation that you have to understand. 5 and 6, the differentiation is that 5 lies between the aorta and the pulmonary artery in the AP window. Anything that lies around the aorta, in front of the aorta, to the lateral side of the aorta is 6. So there is a lot of confusion between what is 5 and what is 6. Most people say 5, 6 is AP window, but 5 is AP window proper and 6 is para-aortic. You're absolutely right. 7?
Subcarinal.
Okay. Is there a right and a left subcarinal?
No, sir.
Good. There is no right or left subcarinal. 8 is?
Paraesophageal.
Okay. Is there a right and a left paraesophageal?
Yes.
Mm.
Yes.
Yes. Not sure, sir.
Okay. So if you're on the right chest, then it is the right paraesophageal. If you're in the left chest, it is a left paraesophageal. But really, it's always called as 8. So there is no 8L and 8R, if you know what I mean. So you can only get 8R if you're in the right chest and doing a right this thing. So there is actually no clear-cut definition in 8L and 8R. It just means that if you're on the right side of the chest and the tumor is on the right side of the chest, it is 8. So paraesophageal is all counted as 8. Okay. Yeah, Pallavi.
Sir, I have a question. We don't divide the 2R, 2L and 4R, 4L also from the midline. We divide it from the right side of the trachea. Is it just by convention or is it a reason?
By convention. It's by convention. Okay. There is no histological to it. Okay. 9. What is 9?
Inferior pulmonary ligament.
Okay. Is 9R and 9L present?
No.
So, sir, it's not mentioned like that, but yeah, it depends on the side we are operating.
Depends on the side you're operating. But traditionally in the classification, in the IASLC classification, the R and the L is only attributed to 2 and 4. And the reason why R and L is attributed to 2 and 4 is because when you do a mediastinoscopy or you do an extended cervical mediastinoscopy, you can actually get to both sides at the same time. And you dissect the right and the left side. So the histopathologist will never know which is R and which is L until and unless you specifically call it R and L. You understand that? So 2 and 4, you can get into the right and the left with the cervical mediastinoscopy. And the reason why it is very important is if it is a right-sided tumor, 2R is N2 and 2L is N3. Okay, so that's why it's important in 2 and 4. But in 8 and 9, you cannot get across the midline to get the other side. So that is why there is no R or L on 8 and 9. Okay? Okay, 10.
Hylar.
Is there an
11
R and an L?
Sir, again, they are not defined like that.
No, there is a 10R and a 10L because when you do extended cervical mediastinoscopy, TEMLA, then you actually do get into the hilum. And so it's important that you tell the pathologist there's a 10R or a 10L because it's all in the midline. So if you take out 10L and give it to the pathologist and that comes back positive and the tumor was on the right side, then it is a N3 node. If you get 10R, then it is a N2 node. Okay, so 10 is important. 2, 4, 10 is important. Okay, next.
11 is interlobar.
Yeah.
12 is subsegmental. 13 is 12 is segmental. 13 is subsegmental, and 14 is.
No, you missed one in between. You missed 11. You've missed. You have actually gone one ahead.
Lobar.
Interlobar, lobar.
Interlobar, lobar.
Lobar, segmental, subsegmental. Okay. So 11, 12, 13, 14 is lobar, interlobar, segmental, subsegmental. Is everybody writing this down? I want you to write this down for the simple reason that the whole talk today is going to be that, and I will show you all pictures, so don't worry about that. Okay. All right. Okay. So let me get back into the gear now. So let me come into the picture. Where am I? Okay, so I want to actually share my desktop with you guys now. Everybody clear about this? Okay, now my question, I want to ask a feedback on who shall I ask? Who is there? Who is exam going? I want exam going candidates, okay? So who else is exam going? Please volunteer. This is a safe platform to volunteer because you will learn here. Who wants to volunteer? Where is Ramaswamy? You want to volunteer again?
Yes, sir. Please.
Come on. Ramaswamy, tell me, put your video on and tell
Yes,
me.
sir.
I asked you a question earlier.
Yes.
What are the types of strategy for biopsying a mediastinal lymph node? And I want you to name me everything that you know. Did you write it down? The answer? Okay, you didn't get time. So go through the various strategies for biopsying a mediastinal lymph node. Tell me all that you know.
Sir, EBUS guided biopsies.
EBUS, okay, all right. Start with something even more basic, okay? So start with the basic and then move on to the more advanced. So what did they do when they didn't have EBUS? What do you think they did? In the mediastinum, if you had a lymph node, what do you think you could have done when you didn't have EBUS?
Open biopsies.
Open biopsy, okay, agreed. Anything else? When the bronchoscope was there, can you think of anything that they could have done with a bronchoscopy but without EBUS? TBNA, transbronchial needle aspiration.
Needle aspiration, yes.
So TBNA for a subcarinal node was quite a standard practice. So that was one.
Yes.
Even before that, they used to do CT guided biopsy. Some people, if they were big prominent nodes, usually mediastinum is not biopsied with a CT, but if it was a big prominent node on the left side, they could try to put in a CT guided biopsy. So the various strategies for biopsying a mediastinal lymph nodes are as follows. Number one is, in the old days, transbronchial needle aspiration. Number two, in nowadays, EBUS guided biopsies. Number three, tell me Ramaswamy, number three.
Sir, mediastinoscopy and
Yeah,
biopsy.
if you can do EBUS, what else can you do? If it is a posterior mediastinal node or something like that, how can you access the mediastinum? Is there any other?
EUS, sir. EUS.
EUS guided. So
endoscopic ultrasound needle aspiration.
Endoscopic ultrasound of the esophagus. Very good.
Yes.
Now talk about surgical options that you have. Mediastinoscopy, you said.
Mediastinoscopy, yes.
Mediastinoscopy.
Cervical mediastinoscopy.
What else? Yes. We'll talk about each one of this in a minute, okay? What else?
Sir, VEMLA and TEMLA, sir.
So video assisted
extended
and
yes.
trans-cervical extended mediastinal lymphadenopathy. Okay.
Exactly.
What else?
So for station 5 and 6, Chamberlains procedure, sir.
Chamberlains procedure. Which space do you go in when you're doing a space?
Second intercostal space, sir, on the left side. just 1 centimeter lateral to the sternal margin.
Okay. What else?
So VATS biopsy, sir.
That's mediastinal lymph node biopsy. What else?
Yes.
Anybody else wants to add anything else? Because
May I add something?
who's that?
We can do thoracotomy.
Who is that?
So Shilpa,
Shilpa, what else?
I'm just guessing. Is it navigation bronchoscopy guided biopsy?
That is, yeah, that is modern, very modern. Good. EMN, I like that. What else?
EMN.
I will show you all of this in a minute, okay? I haven't started my lecture. I'm revising at the moment.
We can do thoracotomy. We can do thoracotomy also.
Thoracotomy.
Very good. Thank you very much.
Oh.
Open thoracotomy, which
Yeah.
could be either posterolateral, lateral, or anterior. Don't forget this. Everybody talks of all the big ones, EUS, EBUS, EUS, EMN, all that stuff, and you forget open thoracotomy. And 95% chance your examiner is somebody who does not do VATS. So don't forget open thoracotomy. That's why I specifically asked this question, because I could have almost bet you that you would forget open thoracotomy. So remember this. I want you to make this mistake so that you remember very clearly in the exam. So open thoracotomy, okay? Don't forget open thoracotomy. And open thoracotomy can be many ways. Okay, so it could be posterolateral thoracotomy, could be just a axillary thoracotomy, could be just a lateral thoracotomy, could be an anterior thoracotomy. Any of this will give you access to a mediastinal lymph node. Okay? So happy with that? Everybody happy with that revision? Is it okay? Makes sense? All right. Now let's get to the mediastinum and see what it's all about. What was the other question that I asked you? I asked you some other question. I forgot now. Okay. So let's get to staging the mediastinum. Okay. One more question. Okay. For who wants to answer next? Where is, who is going, exam going? Come on, volunteer. Vikas, come forward, okay? Vikas, my question to you is very simple. Why want to take the mediastinum? This is the Viva question. I ask this very often in the Vivas. Why
It will help us. It will help us plan the treatment, and it will help us tell the prognosis. For planning the treatment, we have to rule out.
Planning a treatment.
By the planning the treatment, I mean we want to rule out whether the patient has extensive stage disease or it is limited to mediastinum. So whether we can go, if it's a non-small cell cancer, whether we can go for resection or we have to go for the chemo radiotherapy.
Excellent. So one minute. Go slowly.
Basically, we want to rule out it.
One is to plan the treatment, and number two, tell about the prognosis for the patient. I like that answer. And then he said, in treatment, why you want to do is you want to actually stage the tumor. You want to know whether surgery is the therapy or is it extensive disease and is chemotherapy or radiotherapy or whatever else. What else? Why do you want to stage the mediastinum? What else?
It will also tell us what approach, if it's a surgery, what approach will be taken.
What do you mean by that? I don't understand that. What do you mean by that?
How much will be the extent of resection? It will tell us.
Okay, so you're saying it will help you decide whether it's going to be a lobectomy, segmentectomy, or humanectomy?
Yes.
Okay. Maybe not. Okay. I'll take it. What else?
It may also tell us whether we have to go for an open surgery or a wax surgery. The staging will.
I don't think sampling the mediastinum ever has made me change my mind. So I don't think that helps me in my decision. I want you to tell me why else will you stage a mediastinum? Trying to stage it. I will ask you this question. Okay, who wants to go? Pallavi, why do you think
Sir, voice is not clear. I'm barely able to hear.
Okay. Somebody's phone is crackling. I think because your phone is crackling a lot. Yeah. Okay. So my question is, why do you want to stage the mediastinum? So he said one is he wants to decide treatment, whether this is an operable or an inoperable cancer. Number two, he wants to give prognosis to the patient. Agreed. What else? Why do you want to stage the mediastinum?
So because PET is inadequate for staging, especially in countries where there is a high prevalence of inflammatory lung disease.
Absolutely correct. You need to stage the mediastinum to know for the presence or absence of malignancy. You understand? Because it could be benign disease. A PET positive mediastinum does not mean it is malignant disease. You must say this in the exam. That shows that you are a switched on person. The patient may have lung cancer, but a PET positive mediastinum could be because of tuberculosis or could be because of sarcoidosis. And suddenly something that was N2 disease would become an N0 disease and the patient will become operable. Okay? So that's the third point why you want to state the mediastinum. What is the fourth reason you want to state the mediastinum? Anybody else can come in. Ramaswamy, if you know the answer, you come in. I don't mind. What is the other reason why you want to state the mediastinum?
Not sure, sir.
Shall I?
Anybody? Yeah. Who's that?
Shall I attempt? So me, Shilpa. Shilpa.
Shilpa. What is the fourth reason you want to stage the mediastinum?
Sir, we have to rule out the presence or absence of malignancy in the stage N2. Because if N2 is positive, then our line of treatment changes from surgical management to maybe probably neoadjuvant chemotherapy.
That is correct. We just said that actually. The first line was that to decide treatment. So we said to decide treatment. Number two, to decide prognosis. She just said to decide the presence or absence of inflammatory disease. And number four, where do you offer patient EBUS, EUS, or mediastinoscopy? Where else do you offer them? In restaging following neoadjuvant chemotherapy. So when you have given a patient neoadjuvant chemotherapy, you have to restage the mediastinum. You have to repeat the PET scan. You have to, if there is something positive, you have to repeat an EUS, or you have to do, mediastinoscopy in a restaging before you operate on a patient in downstage lung cancer. Does that make sense what I just said?
Yeah.
In restaging, it has a huge role to play. And so in all of these strategies, I will go through the various papers and I will tell you what to do, where and when. Okay? So whenever anybody asks you this question, you must come bang, 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 bang. There are 4 answers for this and it should be very, very precise and clear. Okay. All right. Now I'm going to share my desktop with you guys and I'll start showing you some slides so that you understand what is what. Can you see my desktop? Not yet. Let me share the desktop. Can you see my desktop? Okay, good. So let me just put these all to one side so that you can see the whole. Okay. So staging the mediastinum, quite important to understand how to stage the mediastinum. But this whole topic will not be understood if you do not know the various levels of mediastinoscopy. Okay, so it's quite important. Come on, what's happening? Okay. In the mediastinum, the most important thing is tissue. You need tissue. Now I will ask you, why do you need more tissue? Anybody can take this question, I don't mind. Why do you need more tissue in staging the mediastinum?
To get a more representative sample, sir.
Okay, so number 1, to get a representative sample. Number 2? Anybody wants to tell me what else? Why is tissue
For further,
in the
If
mediastinum?
we want to do immunohistochemistry,
Very good. So to do immunohistochemistry, number 2. Number 3. Anybody wants to tell me number 3?
It is one step procedure to do repeat. If negative sampling has occurred,
Then
then
you have
a repeat.
another procedure. Okay, agreed. What else? Number 3. What am I thinking about? After immunohistochemistry, what do you do? Come on, guys. In a lung cancer case, what do you do in immunohistochemistry? After immunohistochemistry?
Genotypes.
Yes, for genotype. For genotyping and genomic studies of lung cancer. And number 4, for tissue banking. Okay, because in future, if you need any sample to reassess the original reports, then you need to bank that sample into the tissue bank. Okay, so nowadays the world has changed. So it's not just histology, but it's also immunohistochemistry. It is genomics and genotyping of lung cancer. And number 4, for tissue banking. All of these contribute to accurate management of lung cancer. So these are the answers when you say tissue is the issue in the mediastinum. Is everybody with me? Is it making sense what I'm saying? Good. Now, we've spoken about the non-surgical access. I will quickly take you through some of the surgical access. First and foremost, the most commonest one which we used to do for many, many years before the video mediastinoscope came, and that was cervical mediastinoscopy. Once the video mediastinoscope came, we started doing video-assisted mediastinoscopic lymphadenopathy, okay, which is VAMLA. We then started talking about cervical access to get extensive mediastinal lymph node dissection, including station 5 and 6 through the cervical axis. So not just right, left, 2, 4, 10, and 7, but also 5 and 6. And that is called as transcervical extended mediastinoscopy. Okay. The other one we spoke about is anterior mediastinotomy, which Ramaswamy described as Chamberlains operation. That's good enough. Then we spoke about VATS, and most importantly, thoracotomy. Don't forget thoracotomy in the exam, because very likely that your examiner will not know about, will be somebody who doesn't do VATS. Okay. All right. So this is let me just reduce this so that we all can see. So this is standard cervical mediastinoscopy. You make a cervical incision. The trick to dissecting this is that there should be no bleeding. There is no blood vessel which comes in the midline. If you have any bleeding, it means you're not in the midline. You are either to the right or to the left. Very rarely will you get one anterior cervical vein coming up across. But you do not have to cut it, you just retract it laterally. And then you go down up to the trachea, and you have to pick up the pretracheal fascia. See this one, the pretracheal fascia, and that is where you go in. So you have to go between the pretracheal fascia and the trachea, where the mediastinoscopes, and that is where you will get all the lymph nodes. The reason why you have to go into the pretracheal fascia, anybody can tell me what is the reason? What happens if you go extra facial? Anybody can take the question. What will happen if you go in front here?
Injury to the innominate veins.
all the major vessels.
Any of the blood vessels.
Yes,
All
any of the blood
vessels lie outside the pretracheal fascia. So when you're describing cervical mediastinoscopy, you must throw this in, that you pick up the pretracheal fascia, you dissect the pretracheal fascia, and the mediastinoscope goes into the pretracheal fascia, because all blood vessels lie outside the pretracheal fascia, and your risk of injury to the blood vessels decreases. Okay, so it's quite important. All right. So this is how we used to do. These are all the lymph nodes. Forget this. We'll talk about this a bit later. This was the old style. This was cervical mediastinoscopy, and then we got into video mediastinoscopy, where here is the video camera which is attached, and this rod is a rod which goes across the chest of the patient, and it fixes to the camera. So what this lady or this gentleman is doing is he is using 2 hands to do the dissection. And this procedure where you fix this camera to the rod is standard, usually done in trans-cervical mediastinal lymph node dissection. Extended cervical. So TEMLA is the one where you do this. So you fix that camera to a bar, and then you do all of the dissections with 2 hands. The difference between video mediastinoscopy and TEMLA is that in a video mediastinoscope, you just use a normal video mediastinoscope, whereas in a TEMLA, you use an expanding video mediastinoscope. A video mediastinoscope which has a capability of opening at the tip by just screwing a bar. Okay, and so these are all the lymph nodes that you can see in VAMLA and TEMLA, and I'll discuss this in a minute. Just see some pictures. This was just for the lecture. So this is something. So this is what you will see in a VAMLA. Can you see this? 2R, 2L, 4R, 4L, and 7. And this is called as a, anybody knows what this is called as? What is this specimen which goes to the lab called as? A mediastinal board.
Yes,
okay?
mediastinal board.
Mediastinal board. So this is how specimens must go to the lab. They must go fresh, and they must go on a mediastinal board rather than in formalin. Unless it's overnight, then that's different. Because when you put it on a mediastinal board, the pathologist can clearly identify which is what. What is another board that you have seen being used in surgery? Similar to a mediastinal board.
Thymus, sir.
Yes,
Thymic,
thymus board. Always you must send a thymic specimen on a thymus board, and I will show you that when I speak about thymectomy. And that is actually recommended by ITMIC. It is one of the recommendations that all thymus specimens must be sent on a thymic board, in which a normal thymus is drawn and the specimen is placed on the thymus, and each end shows exactly which is the horn, which is the right curve, which is the left curve. Okay. Now this is a mediastinotomy. Can you see this? Second intercostal space laterally, and you put in a mediastinoscope, and you usually do it for going to 5 and 6. Okay, anterior mediastinoscopy or mediastinotomy. Okay. Marcin Zielinski is the name that you have to remember when you talk about TEMLA. Almost all papers in the literature have been published by Marcin Zielinski. He's a very close friend of mine, and he's the guy who has written the most. In fact, he now routinely does trans-cervical lobectomy, wax lobectomy. So he goes in by an extended cervical incision, does all of the mediastinal lymph node dissection, and then goes into the side and does a lobectomy from the same incision without needing anything else. So remember, if anybody asks you to quote any paper, just say Marcin Zielinski et al. From Poland. Okay? Quite important. This is the extended cervical mediastinum. Can you see this? This is a mouth which opens up when you press the screw here. Okay? So when you press a screw, it opens up and you get a wide extended look into the whole of the mediastinum. So this is a TEMLA, a large cervical incision. These pictures are from Marcin himself actually. So he has shared these with us. So he does a wide extension and gets in there, and he can see all of the blood vessels and very, very clearly see all of the lymph nodes. See here, this is the trachea. He's seeing everything here, all to the right, to the left. So really good extended vision, and he can get any single lymph node in any of the areas. Okay, so these are the surgical approaches. Let's talk about the endoscopic approaches. So we have two approaches. One is the EBUS, and EBUS stands for endobronchial endosonography or endobronchial ultrasound. So the correct word is actually endobronchial endosonography. And the other one is esophageal ultrasound, which is esophageal endosonography, EBUS and EUS. Okay. Now this question will always get asked either in the MCQ or in the vivas or in theory. Somewhere this question will come. Which lymph nodes are accessible by which technology? Okay. And it is very important for you to understand this. So EBUS is all on the right hand side. The black is EBUS. So 2R, 2L, 4R, 4L can all be accessed by EBUS. Okay. The ones which are in the distance, 10R, 11, 12, all of this can be accessed by EMN or by EBUS. The EUS comes into its own when you are looking at 5, 6, 8, 9, and more importantly, when you are looking at intra-abdominal lesions, which means in the presence of a lesion in the lung, liver, or lesion in the left adrenal gland, or a para-aortic lymph node in the abdomen. So EUS is very good. But if it is a posterior place 2L or posterior place 2R, EUS can also get to it. Okay, so EUS can get to any of these structures in the midline. 2L, 2R, 4R, 4L, and 7 from the back. EBUS comes from the front and gets them. So take a snapshot of this picture. This is very important. This question will always be asked to you. What stages to use for what? So here it is. EBUS, 1 low cervical supraclavicular lymph nodes, 2R, 2L, 3A, 3P, retrotracheal, 4R, 4L. Okay, quite important that EBUS can get there. EBUS can also get at 10, 11, 12, 13, 14. Now better with EMN. So with EMN, you can actually look at all of these. And number 7. Okay, so this is quite important to understand. EUS can get at 1 because it lies parallel to the esophagus. 2R, 2L, 3A, 3P, not 3A. This is actually a misnomer because esophagus lies at the back. So EUS finds it very difficult to get to 3A. It's the 3P that it can get to very easily, the 4R and the 4L. And more importantly, the 7, 8, 9. These are specifically, 8 and 9 is specifically by EUS, and the intra-abdominal part is all by EUS, including a adrenal metastasis or a liver metastasis or a paragastric metastasis. Okay, paragastric or para-aortic metastasis in the abdomen. So remember, this is quite important. And then nowadays we have got EMN, and EMN gives you further magnification of not only getting the 10, 11, 12, 13 lymph nodes, but also can get you a very small lesion in the periphery. So if you got more than one lesion, suppose you got a tumor in the right upper lobe and a small ground glass opacity on the left and a couple of lymph nodes. So instead of doing EBUS, we will go and do EMN, because EMN allows you to get to the left-sided small ground glass opacity. So this is a further addition on the technology nowadays. And we do it all in a hybrid OR. In London, we've got EMN, and we as surgeons actually do this procedures, and we offer it to our patients. Okay, so this is about it. Now, this is the most important paper, and I am going to share this with you guys now. Okay, so on WhatsApp, if I can bring up WhatsApp, I want you to have this paper and save it into your files. Okay, I've kept it here somewhere. Okay, so this paper is now gone to you. All right, this is the most important paper. I want everybody to read this paper. Okay, it's absolutely mandatory. it talks about when to do what investigation and what is the level of evidence. So when you talk in the exam about staging the mediastinum, you should be able to tell about the level of evidence, okay? So please read this paper. Everybody read this paper. It's a very, very nice paper. And it is, there are two papers. One is the ESTS guidelines, and then this is the ERS, ESTS, and ESGE, which is the European Society for Gastrointestinal Endoscopy. So this is the most important guidelines, okay? So these three have got together and given the guidelines. And now I will take you through all of them. Okay, so this is talking about mediastinoscopy first. So let's talk about what is the value of mediastinoscopy. So with VAMLA, there is a higher number of lymph nodes. And I want you to take down these points that I have put, because this is the message. So all of these papers, you have to put a message. So you should say the Ramipota et al. Have actually done a meta-analysis, and they have shown the following advantages of mediastinoscopy. So VAMLA, the main advantage is you get slightly higher number of lymph nodes than a conventional cervical mediastinoscopy. There is higher number of lymph node stations by VAMLA and better accuracy. So this is conventional mediastinoscopy versus video mediastinoscopy. This was a meta-analysis of all the papers that are published, okay? So that's number one. And the predictive value by VAMLA is higher, negative predictive value, than by conventional mediastinoscopy, because you're actually seeing the node and taking it out on the large screen. The morbidity between the two operations is similar. The mortality is less than 1%, but the accuracy is higher by VAMLA. Okay, so that's the first thing that you have to remember that comes out of these papers, these two important papers that I showed you. VAMLA versus TEMLA, what is the evidence there? Okay, so they have looked at all the main studies that are out there. When you compare VAMLA to TEMLA, there is higher number of lymph nodes by TEMLA. Most important. Higher number of lymph node stations by TEMLA. Better accuracy because you're getting more lymph nodes. The cons of that is there are more morbidity with TEMLA because you are more likely to damage the recurrent laryngeal nerve on the right or the left, and you are more likely to damage thoracic duct on the right, okay? And cosmetically, the scar is not nice because it's a much bigger cervical scar. So if somebody tells you what is the cons of TEMLA, then you have to talk about higher injury to surrounding structure, and cosmesis is not good with TEMLA, okay? So the morbidity is higher by TEMLA. This is quite important. Again, I will ask you, if I hand you a video mediastinoscope, I will ask you, why VAMLA, why TEMLA, what is the benefit of VAMLA, what is the benefit of TEMLA? So you must know this, it's quite important. And you must always say, according to literature. Okay, this is all published literature. Nothing that I'm saying is off the top of my head. So EBUS versus EUS, what is the stage? The sensitivity across the studies of EBUS and EUS is anywhere between 83 to 93%. EBUS is slightly more sensitive in the literature than EUS, but it is very, very much operator dependent, okay? The specificity is 97 to 100%. Remember these two, please write this down. EBUS stroke EUS, the published literature meta-analysis. See, this is a meta-analysis. So the published literature meta-analysis suggests a sensitivity of 83 to 93% and a specificity of 97 to 100%. Just remember this by heart. This will be asked somewhere in the exam. How about restaging with EBUS and EUS? How good is it? Is it any good? The sensitivity drops a little bit when you restage with EBUS and EUS to the level of 70 to 92%. The specificity still remains high at 86 to 100%. Okay? accuracy is 0.6 to 0.90. This is a statistical accuracy, so I would not quote that. I would just talk in terms of sensitivity and specificity. What about restaging with mediastinoscopy? How good is it or how bad is it after you've done? Mediastinoscopy is a pretty good tool, actually. There is a 74% sensitivity and a pretty high accuracy, almost as good as EBUS or EUS in restaging. But the problem is, technically, mediastinoscopy is much more challenging in a mediastinum that has received chemo or radiotherapy. So people will ask you, why should you use EBUS versus mediastinoscopy in a restaging scenario? The answer to that would be that technically mediastinoscopy carries a higher risk in a post-chemo, post-radiotherapy mediastinum. Okay? So here is the problem. Morbidity is 3.9%. Can you see this? This is the problem with restaging with mediastinoscopy, that the morbidity goes up dramatically. In a normal mediastinoscopy, first time, the morbidity is less than 1%. The second time, the morbidity rises to 1.9 to 3.9, or post-chemo or post-radiotherapy, the morbidity rises 1.9 to 3.9. The problem with this, what you have to understand is that morbidity in a mediastinoscopy means bleeding. And bleeding from a central big lymph node is a very dangerous situation, which might need an urgent sternotomy and may even carry a mortality with it. So it is not an operation that should be taken lightly. It is an operation which carries a mortality as opposed to EBUS and EUS. So you should not be, as a surgeon, try to push mediastinoscopy all the time. You must try to quote the literature, and that's why I'm going through all of this according to the literature. So there is a morbidity with mediastinoscopy and a mortality with mediastinoscopy. That is something that you have to understand and you have to talk about in an exam. Okay? All right. So let's look at the recommendation. All right. So what are the levels of recommendation? Anybody can tell me what are the levels of, what do you mean by level 1, 2, 3, and what is A, B, C, D, E? Hello, anybody there? Go on, tell me, what is levels of recommendation?
Sir, is it class of recommendation and level of evidence?
Good, thank you. What is class of recommendation?
Sir,
Here, in this particular paper, there is only class of recommendation, okay? Whereas level of evidence is different and class of recommendation is different. Thank you.
I'm not seeing the video.
Biswaru. Yeah, go on. Tell me what is A, B, C, D, and what is 1, 2, 3.
Sir, level 1 recommendation is one in which the benefit is definitely more than risk, is certainly more than risk. Level 2 recommendation is 2A in one, the benefit is more than the risk. 2B is one where the benefit is, it may be beneficial, may not be beneficial, almost equal to the risk. And level 3 is one in which class of recommendation 3 is one in which the benefit is less than the, risk is more than the benefit.
Okay. What about recommendation grades?
Level of evidence, sir.
Yeah.
A level of evidence A is A is one in which there is very high quality data with more than one randomized controlled trial which proves the definite benefit of the procedure or the intervention. Level of evidence,
not randomized control, but usually meta-analysis.
Meta-analysis, yes, sir.
First, you should say there is meta-analysis, or there's a systemic review, or there is a level 1 RCT. Okay.
Yes, sir.
Okay. B.
B is into two types, BR and BNR. BR is one that does not have a meta-analysis, but definitely has at least one randomized controlled trial to prove the benefit. BNR is one in which there is no randomized trial, but registry studies to prove that there is a benefit. And C comes as expert opinion, EO and LD. EO is in expert opinion by societies or by individuals who have definite expertise, and LD is limited data where there are so rare cases that there is very limited data to comment on the benefit or the risk of the intended procedure or intervention.
Okay. All right. So I'm quite happy with this. I will not go into this because this is not a statistics lecture. When I do the statistics lecture, I will go back into these levels and these recommendations. It's quite important. You must know that 1, 2, 3, 4, A, B, C, D. Okay. It's quite important. So let us look in context of this topic now. I will just quickly go through the finer points. So whatever I'm bringing up, the finer point, this is what you have to write down. Okay.
Yes.
So please let's get on with this. Okay. So in a non-small cell lung cancer with an abnormal mediastinum, which means CT PET positive, there is level A evidence that level A recommendation that endosonography or EUS or EBUS should be done. Okay. So do not try to not talk of EUS and EBUS. There is a level A evidence, that's the highest level of evidence. So if you've got a non-small cell lung cancer with a PET positive mediastinum, the first thing that should come out of your mouth is EBUS or EUS. Okay, I want you to understand this. That's why I brought up these level of evidences. EBUS TBNA is preferred along with an EUS FNA. Okay, but that level of evidence is C, level C. Write this down, okay, and afterwards ruminate over it. Straight away you will not understand all of this. Please write this down and ruminate over it afterwards. If both are unavailable, an EBUS and EUS, then EBUS alone can be used for staging. So this is the first recommendation that has come out of this paper, ESGE, ERS, ESTS. Okay, can you please write this down? This is quite important. I want you to understand. Only if EBUS is negative, or actually if EBUS is negative, but the mediastinum is positive on PET scan, you have to do a mediastinoscopy to prove that that needle biopsy was correct. So you cannot operate on a patient with a lobectomy on the grounds that EBUS was negative, and that's okay. So these are the level of evidence that has come out of this paper. So if EUS is negative or EBUS is negative in a PET positive mediastinum with a confirmed lung cancer, then you cannot operate. You have to actually stage it with mediastinoscopy and get extra tissue. And once mediastinoscopy is negative, then you can say that the mediastinum is negative. Okay? So take your time, write this down. Whatever I've put is the crux of the whole paper. It's a very difficult paper to read, but this is the crux of the paper. Okay? And that's why I'm presenting this to you. Okay. Let's look at the second level. Okay? Are we okay with the first one? Guys, anybody's got any questions? I'm happy to stop. It's quite important. Anybody wants to ask me any questions, stop me here. Everybody's happy? Okay. Now let's look at the second scenario, okay? You have a documented non-small cell lung cancer, but the PET scan is normal. What would you do in this? So the guidelines say that if the lymph node, mediastinal lymph node is enlarged, or if the hilar lymph node is FDG positive, and the primary tumor doesn't take up FDG, or if the tumor size is greater than 3 centimeters, then EBUS or EUS should be done. So you have a primary tumor, mediastinum on the PET scan was negative, but the size of the lymph node in the mediastinum was 2 centimeters, then you should do EBUS, EUN or EUS. If the hilar lymph node was FDG positive, you must stage the mediastinum. Or even if the whole of the mediastinum is negative, but the size of the tumor is 4 centimeters, then you must take the mediastinum before you operate. Very important. Please take this down. This is going to change your practice, what you do. And this is evidence-based medicine. Everything is based on literature. Okay? So second scenario. Is everybody clear? Give me a thumbs up. I just want a thumbs up to know it's clear. Or even if it is not clear, just take it down and afterwards we will, ruminate over it and it will all become clear to you. Okay. If the EUS or EBUS is negative for malignant disease, in these 3 scenarios, you still have to do a mediastinoscopy before you operate on this patient. So if the tumor is large, great, 4 centimeters, and the mediastinum was negative, but EUS was negative, you still should do a mediastinoscopy. But the level of evidence is C. Remember this. So you can argue with the examiner that in India, we cannot afford 2 investigations, or the EUS is negative and I can go ahead with the surgery. You're okay because the level of evidence is C. But in an ideal world, I would have liked to do a mediastinoscopy. That is the answer. You understood that? So this is a beautiful way of representing your opinion. That, sir, the level of evidence is level C, that an EBUS and TVNA should be done. If it is negative, then I personally believe that a mediastinoscopy should be done. But if it's a cost effective or doing 3 procedures is a problem, then you can go ahead with doing the surgery. Okay, because the level of evidence is C. So these were the scenarios that we spoke about. Yeah? Go through this a bit later. Take it down and ruminate over this. This is quite important. So the two pictures which I showed you was this and this. Hilar lymph node and the tumor is here. Peripheral lung cancer, normal mediastinum, ipsilateral hilar lymph node, tumor less than 3. And this one was the second scenario. Okay. Okay. Now, next scenario. Peripheral lung cancer, normal mediastinum, no FDG uptake in the tumor and tumor less than 3. Okay. What are you going to do in this scenario? Normal mediastinum, NSCLC, no enlarged mediastinal lymph node, primary tumor without FDG uptake, less than 3 centimeters, initiate therapy. This is the only place where you should go ahead with surgery or chemotherapy if it's a small cell lung cancer, okay? But this is for non-small cell lung cancer they're talking about. So go ahead and operate, no problems, okay? Take this down, please. Write it in the way I have written in those points and then ruminate over it afterwards and it will all become clear to you. Another scenario. There is a central tumor and each one of this is an MCQ. I promise you, it will come in part 1 and it will come in part 2. And in the Viva also we will ask you. So if it's a central tumor, there is no mediastinal or hilar lymph nodes on CT or PET. You still have to do a EBUS TBNA. In a central tumor, you should still do an EBUS TBNA with or without EUS. Ideal is, of course, when you do EBUS and EUS together. But it's okay if you don't do an EUS, but at least an EBUS should be done to stage the tumor in preference to surgical staging, okay? So just an EBUS is the right answer here rather than mediastinoscopy. Level of evidence is deep, but it is quite an acceptable way. Expert opinion. If the endosonography is negative for malignancy, if EUS is negative for malignancy, a mediastinoscopy is indicated in a central tumor, even though the CT and the PET was negative. Write this down, please. Take your time and write this down. Is this clear? Is it making sense? It may or may not make sense straight away, but when you ruminate over it, it will all come back to you. You will understand exactly why we are saying what we are saying. So central tumor with a normal mediastinum. This is a very classical question asked in the exam. An MCQ will come, they'll give you a scenario, a CT scan showing a central tumor, and the next step would be surgery, chemotherapy, radiotherapy, EBUS. And you'll think, central tumor, mediastinum is normal. Why should I do EBUS? Let's offer surgery. And then suddenly you find that's a wrong answer because the recommendation is EBUS. Okay. Next scenario. What about restaging after neoadjuvant chemotherapy? What should you do? Once you've given neoadjuvant treatment, how should you restage? So they're saying that treatment or the modality of choice is actually an EBUS. Okay? Because mediastinoscopy carries a higher morbidity, 1.9 to 3.7% morbidity. So when you're restaging, it's better to restage with an EBUS TBNA and or EUS. Okay, so that's not a problem. You can add an EUS if the node is in 5 or 6, then you can add an EUS to the EBUS as well. But if it is negative, then mediastinoscopy is recommended. You cannot operate on this patient with a slightly positive, PET positive mediastinum and a reduced tumor following downstaging. And you cannot say, oh, it's downstage and let me just go ahead and operate. You have to prove that the mediastinum is negative. Only then the prognosis is better when you operate. Does it make sense? What I'm saying, is it making sense, guys? Good. Okay. Let's go to the next one. A non-small cell lung cancer with an abnormal mediastinum. The assessment of the complete mediastinum and hilum is needed. At least 3 stations should be sampled. This is an MCQ. That we sample level 2 and 4. Is that okay? That is incorrect. The correct answer is the ASCOG Z00300 study categorically stated that at least 3 lymph node stations have to be sampled. And the NICE guidelines for management of lung cancer also states that any staging has to sample at least 3 stations. So remember this, you cannot just do one paratracheal node and say, okay, that is negative. You actually have to get into 3 levels of stations before you can call it. And the minimum that is accepted is 4L, 4R, and 7. Minimum. If you do more than this, it is recommended that you do more than this. But minimum that is accepted is 4L, 4R, and 7. Are you okay with this? Everybody's understanding what I'm saying? Okay, there's a big group today, so I can't see everybody, but the first 2, 3 are showing me a thumbs up, so that's good. Okay, the next level of recommendation says that in a central tumor, not visible at bronchoscopy, an EBUS is recommended or an EUS is recommended. We spoke about what is the modality. So though the tumor may not be endobronchial, but EBUS will actually help you get a biopsy, okay? And EUS will help you to get the lymph nodes from the outside. In an enlarged left adrenal gland, what do? Do you operate? A tumor in the lung and an enlarged left adrenal gland, what do you do? You have to prove it that it is not a metastasis. It is mandatory to prove an adrenal gland is not a metastasis, because lung cancer goes very often to the adrenals. And the best way to get into the adrenal is either a CT guided biopsy or do at least an EUS FNA. But for an EUS FNA, you need a very experienced guy who can work his way around into the adrenal. Or the CT guided or an ultrasound guided biopsy is good enough. But you have to biopsy the adrenal.
Sir, is a PET CT, can a PET CT be done in this case?
You can do PET CT, but even if it's negative on a PET CT, I would prefer to biopsy it unless they are categorically telling you it has features of an adenoma.
Okay.
An adrenal adenoma has separate features, which the radiologists are very, very confident. When it's an adenoma, they will tell you it's an adenoma. But most of the times when there's a lesion, nobody wants to take the risk. So the last thing you want to do is miss a metastasis in the abdomen. So if you got
Sir,
yeah, sorry, who's that?
So Pallavi here.
Yeah.
Solitary adrenal metastasis is not really a contraindication to surgery, is it?
It's not a contraindication, but you need to know, because you have to take out that solitary adrenal metastasis at the same sitting, so that you do what is called as oligometastatectomy plus surgery. So it's not about contraindication, it's about documenting. If you miss the left adrenal lesion, that will metastasize further. Okay, so it's not about contraindication, it's about documentation that it is actually a metastasis. And you should document this before surgery, before the lung surgery. Okay. And one more thing I forgot to say is they are now talking about transgastric sampling of these abdominal lesions. Okay, now some few things they're talking about training issues. I think it's important you have to talk about training issues, that both EBUS and EUS should be trained, and there are very detailed levels of how many cases you have to be done, and simulation and practical training, and about competency assessment. So that's all right, you don't need to know this too much. So this is the key. Everything that we spoke about just now is in this paragraph, and this is there in that paper which I've just uploaded. So when you read all these recommendations which I made, follow this chart and all the recommendations will become clear to you. Okay, what to do when. So CT PET, mediastinal negative, mediastinal positive, N0 less than 3 centimeters, peripheral tumor, go straight to surgery. If it's a central tumor, tumor greater than 3 centimeters, tissue confirmation by EBUS or EUS or VAMLA, video assisted mediastinoscopy. If it's negative, go for surgery. If it is positive, then you have to go for multimodality. If the mediastinal lymph node is positive, you have to always confirm with an EBUS. And if EBUS is non-conclusive, you cannot go for surgery. You have to actually do mediastinoscopy. And then after mediastinoscopy, if it is negative, here it is. If it's negative, you have to do VAMLA and then go for surgery. Or if it is positive, then you have to go for multimodality. So this is the crux of staging the mediastinum. But all of this table can only be understood when you follow the previous guidelines. Everything that I have said, if you have written it down, take each of that group of statements and try and apply it to this table. And then you will understand what is the recommendation. Okay? So quite important. This is really the key to all management, and not just for studying for exam. This is key to your clinical practice. This is called as evidence-based medicine. So you make a decision on the basis of this, you're at least following the literature. Okay? And then sometimes you have to make decisions on availability of resources. Like if you don't have an EBUS in your city, then that's life. You can't do anything about it. Then you do a mediastinoscopy, that's a different thing. But if you want to follow evidence-based literature, evidence-based medicine, then this is the thing. So in an ideal scenario. So issues in India are of course availability. That's the most important issue for all of you guys. But in an exam, availability is not something that you can talk about. You have to talk about what is the ideal management of the patient. Training is an issue because a lot of people are walking around with e-buses and trying to, do e-buses on everybody, but not everybody is adequately trained. And most important, do you know what is the most important thing about e-bus? Anybody can tell me what is the shortcoming of e-bus? Why is e-bus a problem? Because it's not about the competency of the pulmonologist. It is about the competency of the pathologist, the cellular pathologist, to diagnose cells. ROSE, which is rapid on-site examination, is recommended on every patient who has EBUS. And not all cellular pathologists are good enough to be able to give you an answer on the small tissue that you provide. So the problem with using EBUS or EUS is not the technical ability of the performer, but more important is the technical ability of the pathologist to be able to give you an answer. Okay, and again, I'm trying to tell you these points because when you discuss in an exam like this, it's a mature level of discussion. Okay, when you say that, yeah, I've got a very good EBUS guy, but my problem is my pathologist is crap. He cannot diagnose cellular pathology. So then I know that you have actually done work and you know what you're talking about. Okay, cost is always an issue, and in India, cost is a very, very big problem because each of these tests are expensive, 25, 30,000, it adds to the thing. And as I said at the end, the histopathologist is quite important. Now, these 4 points, you keep it in your mind. So when you talk in an exam, you talk about evidence-based medicine, but say in India, the issue is 1, 2, 3, 4. Okay? Then the examiner will ask you, what do you next? But in an FRCS, we will not accept this. In an FRCS exam, if you tell me that, but I don't have EBUS in my city, we're not interested. In an FRCS, you have to talk what happens in the Western world in level 1 countries. Okay, and that is the answer I want to hear. Okay, so tissue is the issue, most important. You need tissue. And again, you must know why do you need tissue. There are 4 reasons you need tissue. One is, of course, for diagnosing, particularly things like lymphomas and all are very difficult, and you need more tissue to diagnose lymphomas, or small cell carcinomas are very difficult to diagnose on FNAC. You really need more tissue. And then the second thing is you want to do immunohistochemistry. The third thing is you want to do genomic studies and gene karyotyping. And the fourth thing is you want to use the tissue for tissue banking for future studies of the patient. Okay, does that make sense? It's very important. So why mediastinoscopy? I personally prefer mediastinoscopy because I give you more tissue. You get just that little strand of things, but I have to go according to guidelines. So the second level is mediastinoscopy. Now the first level is always EBUS and things. Okay. A little bit about mediastinoscopy for benign diseases. These are the common things that we see. Lymphoma is not a benign disease. I'm sorry about that. Lymphoma is always a very difficult problem. So that's what it is. Okay, I'm going to stop here for a minute and I'm going to take back my, I'm going to stop the screen share. Where is it? Hang on. Okay. Stop. Don't say come down there. And I need to stop screen share. Where is it? Stop share. Okay. So now I want everybody to get back into the group, and this is actually a very complicated issue. But if you follow the points that I told you, I promise you, you will crack your exam. Everything that I told you is all evidence-based. Everything is all A-level thinking. When I want to ask you a question, a lot of questions come from this group of staging the mediastinum, because there's a hell of a lot of controversy about the mediastinum. So there's a lot of controversy about what to do, what is the treatment, what is the correct thing. We don't know the answer, but at least if you follow the guidelines, you will look like a very mature person who is talking, at my level of thinking. And almost all questions, at least every line that I gave you, some question will come either as an MCQ or in the Viva or in the clinical exam. I promise you this, I can put up a CT scan, show you a mediastinal lymph node, and then ask you, what investigation? How will you access this? What is the best way to access this? What is the recommended way to access this? So it's quite important, okay? All right, now I'm quite happy to take questions from whoever wants to ask me questions. Did this talk make sense to you? It's quite important. It's a difficult talk. I sometimes feel that if you have not read it well, you will not understand everything that I told you. So I hope this talk made
It's 12 o'clock.
Yeah, go on. Give me 1 second. I need to put my laptop on power. For some reason, it is not on power. 1 minute. Yeah, go ahead. Yeah, tell me. Who wants to ask questions?
Sir, could you, sir, the article that you've shared on the WhatsApp is, I think, the 2013 version. And the guidelines that we were discussing is probably 2015.
I'll share the most recent one with you. I'm sorry, I just literally just come from work and rushed to find all of this. So I was operating all day. So I'm sorry about that. I'll get you the latest version. I've got it. I'll send it to you on WhatsApp. Don't worry about that. Or if you go online, you'll get it. It's not a problem. But I'll send it to you. What else? Questions?
Sir, for a station 5-6 mediastinal lymph node, if the EBUS is inconclusive, what is the best second best option that we have? Because there was one patient, 47 male smoker with the station 5-6 lymph node on CT scan, had two EBUSs done at CMC Vellore, both were inconclusive, and he had come and wasn't following up. So we had attempted doing a VATS on him, and we had sampled the lymph node, but while sampling station 5, there was a sudden gush of blood, and we had to do an emergency stenotomy, go on pump, and repair because it was a contained aneurysm of the arch of the aorta, and he later needed a
Okay. Let's because there are a lot of people on this group. I will address your question directly. I'm not going to address it as anecdotal episodes. So a station 5 and 6, in my hands, the best access is VATS. In the hands of a not so experienced VATS surgeon, the best access is either a anterior mediastinotomy or open thoracotomy. That is the answer in the exam. I know you had a very bad experience, but we cannot talk about anecdotal episodes. So what you have to say is, that in the hands of an experienced person, that is the best access to 5 and 6. In the hands of a less experienced person, either an anterior mediastinotomy or a thoracotomy is the access. Okay. So yeah, next.
Thank you.
I mean, I understand what you're saying, and that's rare things which do happen, and shit can happen to anybody. If you didn't realize that there's a pseudoaneurysm and you biopsied it, that's real bad luck. That's just life. Pseudoaneurysm could have been caused by the EBUS. I hope you realize that. Because the CT scan was done,
twice
there was a 5 and 6 lymph node, they did an EBUS, they punctured the aorta, that gave you a pseudoaneurysm. You did not repeat the CT scan. You went ahead and did the surgery, and you didn't know any better. So you biopsied that, and so that is the sequence of events that's happened. EBUS can cause pseudoaneurysm. If you put needles into aorta, is not a good idea. When I was giving this lecture, there was a pulmonologist who was presenting, I routinely do trans-aortic lymph node biopsies. Okay, and I told him, listen, you may be doing regularly. I'm the guy who salvages these. So don't talk shit in this audience, okay? Don't give advice of people to do trans-aortic lymph node biopsy. And he said, there is published literature. I said, yeah, but what is not published is the complication that happens. Exactly like the case that you told me about. So I'm pretty certain the pseudoaneurysm was caused by 2 EBUSs.
He had 2 EBUSs.
Yeah, so that's what it is. Okay, next. Any more questions? Yeah, Pallavi, I think.
And
Sir, in the Indian scenario, would it change the second recommendation that we had wherein we have a peripheral tumor less than 3 centimeter PET negative?
Second, I don't remember what is the second recommendation, but if it is a peripheral tumor less than 3 centimeter with a negative mediastinum, I would operate on the patient.
Sir, PET negative, would we go for a EBUS EUS, or because based on this guideline we won't, but in Indian scenario, would that change?
No, I would operate on the patient. Why would, if it's a PET negative mediastinum, why would I want a biopsy? Are you suggesting that there's an enlarged lymph node?
No, sir. Generally there are certain centers which recommend routine mediastinal staging as a.
That's incorrect. In fact, almost all these centers which talk about mediastinal staging in a peripheral tumor less than 3 centimeters, you would not stage the mediastinum, a PET negative mediastinum. So no. Okay. Next question, please.
Do you have some CT images which will tell us which lymph node station is?
Good question. I will bring it up for you next time. I'm sorry, I didn't prepare.
I messed up. I messed up in my exam in that thing. I was not able to identify paratracheal.
When I do radiology with you guys, I will show it to you.
Yes, sir.
When we did radiology at Medanta, we covered all of this. We showed so many images. But I didn't, in this lecture, I didn't bring it. I'm sorry about that. Next time when I do radiology with you, I will bring it. Remind me, Vikas.
Yes, sir. Yes.
I will show you. We did that radiology class in Medanta, that late night class, and in that we covered this actually. We did get a lot of CT scans, but I'll get you the images, not a problem. Okay, anybody else? And that is why I'm saying, because this is very important. The mediastinum is the graveyard for thoracic surgery. Really. So that is why you cannot just guess an answer. It's better to follow this paper, which I showed you, and say, according to this paper, this was the recommendation. Then you're safe. Then you're safe. Then you should not try to deviate. So it is the graveyard. A lot of people fail in the mediastinum. Even as surgeons, sometimes we don't know what is the correct answer. Even though we have all these recommendations, but as surgeons, when I'm faced with this situation, sometimes I have to think very hard about what is the next step. And I have access to everything. Even in India, in Medanta, I have access to everything. I've got EUS, I've got EBUS, I've got everything. The whole ball game I've got. And I have to think very hard what to do next. Okay, next question. Just a quick feedback, okay? Was today's lecture clear? Did you understand what are the points I was trying to make? Rather than having you guys read through this extensive paper, I tried to pick up some words and some points which actually are the crux of that paper. Was it worth doing it like this? Because this is the graveyard. This is where most people fail. And so whatever I've said, if you quote it in the exam without thinking, you'll be okay. Okay? All right. Anything else? Good. Lots of thumbs up. So I'm happy with that.
Sir?
Tell me.
Yes. So this is Ramasamy, sir.
Yeah.
So, sir, during TEMLA or VEMLA, do we really do a lymph node sampling or a lymphadenectomy totally?
The people who do TEMLA, they say they are doing a lymphadenectomy, but that is incorrect because you will always leave something behind. You know, you'll always leave something behind. You say you're doing everything, but you're not really taking away every single piece of fat, are you? So
that's right.
Really a systematic mediastinal node sampling rather than a dissection. So, in fact, if you quote the ASCOG Z0030 study, ASCOG Zoo 30 study, it's a large series of many thousands of patients, and they have said that systematic mediastinal lymph node dissection offers no prognostic benefits over systematic mediastinal lymph node sampling. It's a very important statement I've just made. So if somebody tries to argue with you in an exam saying you must dissect everything, then the ASCOG Zoo 30 study says there is no benefit of dissection over sampling. And that is why the NICE guidelines say that at least 3 stations. It doesn't talk about systematic dissection. It talks about sampling. At least sample 3 stations. And the minimum 3 stations is 4L, 4R, and 7.
Yeah. That's right.
Sorry, go on.
Thank you, sir. Thank you.
Yeah, no problems. Next, who wants to ask me the question? Anybody else wants to ask questions? Are you happy? Okay, if you guys are happy, then I'm happy. I'm quite happy to sign off. We had 21 people online today, which is a really good number. Last time we had 25. So I'm happy to see that this group is going well. And it's we are making a difference. So I'll try and stick to Friday evenings. The only problem is now in London, they have made Fridays as my operating day. So I always hope that I finish in time to rush back for this session. And if I can't do it on Friday, then we'll try and do it on a Saturday. Okay?
So what is the next topic that we are going to take up, sir?
यार अभी तो mediastinum खत्म हुआ, चाय पीने दे मेरे दोस्त, फिर next topic बताऊंगा. I will let you know.